Oh. This lab on Neurosurgery TV.
Hi, John.
Hi, how you doing?
Fine.
Dr. Shah?
Yeah.
You're a good student.
Hello, John. How are you?
Good. How you
What's
doing
that?
this morning? How you doing this morning? Hey, are you back?
When do we start, John?
Yeah, you ready?
I'm all set.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, it's Dr. John Bennett from Miami Beach, the home of Neurosurgical TV. We have another episode of the Daily Dose of Neurosurgery Education led by Ip Cherian from Bharatnagar, Nepal. And I'll just turn it right over to Ip. Morning, Ip.
Morning. Well, good evening here. So we're going to see the classification of the carotid, and after that we're going to see the different parts of the cavernous sinus, and then we will see a paraclinoid aneurysm. So this is what we'll be discussing and we'll be seeing today. So I'm going to share my screen right away. Can you see my screen, John?
Yeah.
Okay, let's go. So we are starting with the simple classification of the carotid. This is a classification that we started. We published it as well. So it's very simple. You can see from anterior to posterior, you can see C3, C5, C7. So they are from C3 is anterior, C5 is posterior, and C7 is posterior to C5. So these are the vertical segments of the carotid. Now, as we go forwards, I'm going to connect this C3 to C4, C3 to C5 with C4. So that is a horizontal segment, and C5 to C7 with another horizontal segment, that is C6. So you have a vertical segment C3, which is paracellular, another vertical segment, which is paraclival, that is C5, and another vertical segment, that is parapharyngeal, which is C7. You connect C3 and C5, you have a horizontal intracavernous segment. So you have the C3, the paracellular segment, the horizontal intracavernous segment. Then you have C5, paraclival segment. You have the petrous segment, that is C6, and then you have the parapharyngeal segment. This is the classification of the carotid, extradural carotid. Now let's see further. I hope it is very clear to all of you. Very simple, paracellular C3. Okay. Now we're going to add some more structures into it. Okay. Now, cavernous sinus is going to be from C3 to C5. All right. The cavernous sinus is going to be from C3 to C5. So C5, C4, and C3, that is the cavernous loop. Okay. And lateral to that, you have V1, V2, V3, and the Gazerian ganglia. Okay. So we've added the first layer of nerves there. And parallel to the C6 segment, that is the petrous segment, there is a nerve that runs, that's a GSPN, we all know, just on top of the C6 segment, that is a GSPN. The GSPN joins with the lesser petrosal and becomes the Vidian nerve at the C5 region. So the C6 to C5 region is called the Foramen Lacerum. Am I audible to all of you? Am I audible?
Yes, you are.
Yes, you're audible. Go ahead.
Yes.
The C6 to C5 transformation region is called the Foramen Lacerum. So you can see, one second. Yeah. You can see that at the petrous and paraclival, that is the C6 and C5 junction, the GSPN nerve, it has already become the Vidian nerve. So the Vidian nerve is a good marker for that region. That region is called the Foramen Lacerum. So we have added the first layer of structures here. That is V1, V2, V3, and the Gazerian ganglia, lateral to the cavernous sinus, and the corresponding segments of the cavernous sinus at in the carotid are C5 paraclival, C4 the horizontal intracavernous, and C3 the paracella. So let's go forward. Now we have added the petrolingual ligament, which is again at the foramen, just above the foramen lacerum. So medial to the Gazerian ganglion, if you take off the whole Gazerian ganglion, you're going to see this petrolingual ligament. And this is very important in endoscopic surgery to mobilize the carotid. Now, if you go behind the C7 segment, you're seeing that the C7 segment or the parapharyngeal segment is coming up anterior to a structure, and that structure is the cochlea. And also you can see the upper part of the clivus and the posterior clinoid process, just behind the C5 or the paraclival segment. And of course, you can see now I'm going into a more schematic way. So anteriorly, the vertical segment that you see is C3. And the green structure above C3, is the anterior clinoid process. The horizontal segment distal to the anterior clinoid process is the intradural carotid, or the C2. The two cranial nerves that you're seeing there is the third and fourth nerve. You can see the horizontal intracavernous segment, and then you can see the C5 or the paraclival segment. You can see the green structure, which is the clivus and the posterior clinoid process. And then you can see the V1, V2, and V3. You can see the GSPN continuing as the Vidian nerve. You can see a structure lateral to the C6 carotid, that is the eustachian tube. And you can see another structure posterior to the C7 carotid, and that is a cochlea. The only thing you missed is C5, C4 junction. So you see a red vessel, small vessel taking off behind the posterior clinoid. That's a meningohypophyseal trunk that will give rise to the artery of Bernasconi-Casanari, and most petroclival and tentorial meningiomas are fed by it. So let's go further. So things are a little bit more clearer, I guess. Now let's go into this structure. Now earlier, if you had seen this, you would have been pretty confused. But now, let me tell you. I don't know how to point on the screen, John. I mean, can anybody do this pointing for me? I mean,
Well, can you see my point? Can you see mine or no?
no, I cannot.
No, okay. Okay, I think you may have to go into the settings, but I'm not sure about that.
Maybe somebody else can do it. I mean, I have seen somebody else doing it when
Like a remote arrow or something like that?
yeah. I was thinking if, but okay, let's see. Can everybody identify the optic nerve? Yes?
Yes.
Right. So can you identify the ophthalmic artery?
Yes,
Yeah.
I
Yes?
go ahead. Yes, I.
Excellent. So the first vertical segment below the ophthalmic artery is C3. Everybody is clear about that segment? Yes?
Yes.
Yes.
Now you can see the proximal and the distal dural rings. And below the proximal dural ring, you can see the third nerve and the fourth nerve. And then you see a segment which is not really horizontal, but not really vertical as well. So behind the C3 segment, you can see the horizontal intracavernous segment. The horizontal intracavernous segment. And then behind that, you can see the paraclival segment. The paraclival segment is the vertical segment which is behind C4. Can everybody see that? Yes or no?
Professor, can you
Yes.
just go to the view options at the top, and then you'll be able to use your cursor to show
View options.
at the top of the screen.
I'm at a loss
can see.
to. No, I
Okay.
cannot.
For some reason, we also can't do it. Maybe they've stopped that
Let me see.
function.
Let me see. I cannot somehow.
Sir, I can't help you. Here.
It's okay. It's all right. See. So what I'm showing a loop there, and the first anterior part of the loop, the vertical segment is C3. The most posterior part of the loop is C5. C3 and C5. And then things are clearer. Then you have the third and fourth nerve running there. You have the V1, V2, V3 running there. And medial to V1, you have a small vessel, small nerve coming in from the posterior fossa through the Doralose canal. That's the sixth nerve. I think this is going to be confusing because we really need the pointer here. Let me figure out a way to do that. And before that, let me go into the the paraclinoid aneurysm. Once you know that kind of, once you know that kind of an anatomy, we can go into the paraclinoid aneurysm there. Are you seeing this aneurysm? Are you seeing this aneurysm, everybody?
No, it's
Can you
not
see
clear.
Yeah.
Yes.
Can you see the clinoid?
It's
Yes?
unclear.
Yes.
Not clear.
Okay. Look to the center of the field, and then you can see the clinoid process. Don't worry about what is on the left side of the field. Just look at the middle of the field, almost the middle of the field.
Okay,
The white
yes.
thing. Can you see the clinoid?
Yes, yes.
And touching the clinoid is the aneurysm. Can you see the globular structure touching the clinoid? Can you see that?
Yes.
Yes.
Everybody?
Yes, yes.
Right.
Yes.
So you can see the clinoid. Can you see? Can you see the planum? If you see the clinoid, can you see the planum?
On the right, right?
On the right side, exactly, on the right side. So can you see that this clinoid is literally touching this aneurysm, and this aneurysm is a ruptured aneurysm. Can you see that? Everybody, can you see the aneurysm touching the clinoid process? Yes?
Yeah, it's a lateral paraclinoid.
All right. So how would you guys go for this aneurysm? How would you guys operate this aneurysm?
I would go from the left diagonal, maybe.
Yes, of course. You have to go from the left.
And then
We have to do for
The extradural.
drilling of anterior clinoid process.
Yes, extradural and intradural.
We have to do we have to cut.
intradural.
We have to cut the dural ring, the distal
Yes,
dural ring.
not only you have to cut the distal dural ring, you have to go into the, literally you have to go into the cavernous sinus. You see, this aneurysm, part of it is below the clinoid process. So that means it's a transitional aneurysm. So which means you have to literally cut the proximal dural ring. And if you cut the proximal dural ring is actually the roof of cavernous sinus. So if you're cutting it, you have to go into the cavernous sinus. So you have to see the C3 segment, which is going into the cavernous sinus. Obviously, you have to do that. Otherwise, you can just hope for the best and then clip it, which you don't want to do it in this kind of an aneurysm. So obviously, you have to drill the anterior clinoid process. You have to cut the proximal dural ring. You have to cut the distal dural ring. Of course, you have to do all that. But how are you going to take out this clinoid?
And we also have to take the proximal control in the cervical internal carotid artery.
100%, 100%. If you don't do that, you will be a very confident guy. I mean, an arrogant guy who will look like an idiot if this aneurysm ruptures. Okay, I have seen people doing that, and I mean, fortunately, I have not been that arrogant. So if this aneurysm ruptures, then you will look like a complete idiot, because this aneurysm, you will not see anything. The brain is going to swell, and it's right at the base. And this aneurysm, this is not a ruptured, and this is not an unruptured aneurysm. It's already ruptured, maybe ruptured 2 or 3 days before. So you definitely don't want to take that risk. You don't have to, put a temporary clip or anything. You just have to expose the carotid and just keep it there. Right. Anything else? Are you seeing the aneurysm very clearly now?
Yes, yes.
Are you seeing the ACA, MCA?
Yeah.
Yes.
Trace the carotid back,
Yes.
and then you will see the ACA, MCA. You're seeing the ACA, MCA?
Yes.
Right. So now we are going to go ahead with this aneurysm.
This aneurysm is arising from the siphon, right?
No, this aneurysm is a transitional aneurysm, which the neck is proximal to the proximal dural ring.
And it's pointing posterior. And it's pointing posterior.
It is pointing posterolateral.
Posterolateral. Oh.
Yeah.
Yes. Okay. So when I put the clip, so you need to put the clip parallel to the carotid. All right. You need to put the clip parallel to the carotid.
Parallel to the carotid, yes.
Yes.
On the under surface also.
Yes, the clip has to go to the undersurface as well. Okay.
Yeah.
Right. We're going to see that now.
Do you routinely expose the neck for these cases or not?
Beg your pardon? Who's this?
It's Chris from Johannesburg.
Chris,
do you routinely expose the carotid in the neck for proximal control when you do these?
Of course.
All
of
right,
course,
cool.
Chris. This will be idiotic if I don't do that. I was just telling them.
Cool. Thanks.
Right. So we are, well, this is the aneurysm. You can see it's a transitional aneurysm, literally. I mean, it's not cavernous aneurysm, but it's transition. You have to expose the cavernous sinus to get this aneurysm. Otherwise, you cannot clip this aneurysm. So I'm using the diamond knife there.
Okay, Prof,
and I'm doing the orbital. Yes.
There was no subarachnoid hemorrhage in this case, I assume.
Of course, there was a subarachnoid hemorrhage because this aneurysm is coming into the subarachnoid space as well. That is what you need to see about transitional aneurysms. These are very, very interesting aneurysms. They're not purely into the subarachnoid space, but they can produce subarachnoid hemorrhage. So this is an example of a transitional aneurysm. So have a look at transitional aneurysm. Now what we are going to do is we're going to do the peeling of the temporal lobe away from the cavernous sinus so that I can start doing an extradural drilling here. Okay, let's do that now. So I'm using a diamond knife. You can see the sphenoid ridge which is removed as much as possible. And now I am iPad is not the greatest thing to. Okay. Can you see me cutting that small strands there very gently? Yes or no?
Yeah.
So that's a diamond knife, and I'm doing a orbitomeningeal band and the true cavernous sinus, true cavernous membrane. I'm dissecting it. I'm dissecting the temporal lobe away from the true cavernous membrane. You can see that. You can see those strands under very, very high magnification. You must understand that is a 2 millimeter suction. So you can understand the magnification that I am in. Oh, God. Okay. Let's go ahead and dissect that further. Keep on opening that. Keep on opening that. This is the first step of this aneurysm. Remember, now once I did that, lateral to the clinoid process, the remainder of the clinoid process, you can see the cavernous sinus. Can you see where I am dissecting right now? Is where the superior orbital fissure, the cavernous sinus gets into the superior orbital fissure. Can you understand what I'm talking about?
Yeah.
Yes.
Yes or no?
Yes.
My suction
Yes, sir.
is at the junction between the temporal lobe and the frontal lobe. Can you understand that? My suction is at the junction of the left frontal lobe and temporal lobe. Yes or no?
Yes. Yes, sir.
Right. So what I'm doing is I am defining that clinoid. This clinoid, I cannot be rough here because this clinoid is touching that ruptured aneurysm. So I'm going to drill off this clinoid first at low zoom. Clinoid as well as the roots of the clinoid. I'm not worried about the clinoid as such. I'm going to drill all the bone in that region. I'm not going to define it as clinoid or anything. Clinoid and optic roof, I'm going to drill off as much as possible. I'm going to skeletonize it. I'm just going to skeletonize the optic roof. Now I am at the optic roof, completely underwater. I'm going to thin down all that bone and then go attack this clinoid. And this clinoid, taking out this clinoid has to be very, very, very careful. Cannot afford any mistakes. Can you see the blue lining of the optic nerve? Right of my suction, right of my drilling, I'm already thinned out the optic roof. Can you see that?
Yeah.
Now
Yes.
I am shelling out. Just right of my suction is the optic roof. Where I'm doing right now, that's the optic roof. Okay. Now I'm going under very, very high zoom. Defining that clinoid a bit more. And then under very high zoom, I'm skeletonizing. This is a 2 millimeter drill. Same as that of the suction. Okay, 2 millimeter drill. And under very, very high magnification, I'm going to paint off that clinoid. Okay, it's not drilling off, it's just painting off. The suction is my proprioception. It helps me to feel how the bone is moving. Thinning out the bone, just painting it out. You must understand I have the aneurysm underneath that.
How you can work safely without navigator in this area, please?
Beg your pardon?
One more time.
I didn't
How
get your question,
you
please.
can work safely here without navigator? How you can work safely here without navigator? You are just touching the optic. How you can work here safely without navigator?
No, I don't need navigation here. I really don't need navigation here. I mean, it is just anatomy. It is pure anatomy. There is no need at all for navigation. Medial to my drill is the optic roof. Lateral is the clinoid. Underneath the clinoid is my carotid. And medial, I mean, between the optic nerve and the carotid is my strut. So I will show you. There is no need for navigation. And you will even see the aneurysm right now.
And I think it's also because all this work is extradurally.
Yes, I have the dura between me and the aneurysm, and that is the only thing I have. Okay, I am on thin ice. When you take a sled over thin ice, I mean over a lake or something, this is exactly the feeling that you will have. When you run over the lake and you know that the ice is thin, this is the feeling that you have. Okay, you have only the dura. So
what are the chances of rupture of aneurysm during drilling, sir?
If there is a rupture of aneurysm, okay.
What are the chances?
Beg your pardon?
What are the chances of rupture of aneurysm during drilling, sir? And how do you manage if it is ruptured?
Okay, it's almost nil. Okay, because I'm using no force at all, and the dura is between me and the aneurysm. And once you reach into that level of an experience, it's almost nil. I'm not even thinking about it, because if I think about the aneurysm rupture, it will rupture for sure. It is like walking on a tightrope line. Okay, if you're walking on a tightrope line, if you look at where all you can fall, then definitely you will fall. There is no question about it. You have to look at your next step. Okay, and then your hands will be lighter. If you think about the aneurysm where the aneurysm will rupture, what are the chances? For me, the chances are nil, nothing. But of course, it has ruptured for me. In this case, you have to immediately clip. You have to put a clip, or you have to occlude the cervical carotid. And once you occlude the cervical carotid, once you have done at least this much bone work, the aneurysm is going to be accessible. And once you put a distal clip also, you can very aggressively, I can show you another rupture also, intraoperative rupture of a paraclinoid. I can show you if you guys have time. I mean, Professor Goyal will be waiting. So, but maybe tomorrow or any time when you are free, just remind me and I'll show you a few paraclinoid ruptures. Okay, then you will see that it is actually a rupture is easier for you. Okay, now I'm going to go ahead with this. I'm going to thin down the bone furthermore. You can see on the right side of the field, you can see the optic nerve roof is completely exposed. You can see the blue lining. The clinoid is completely thinned out. Okay, but I'm not going to mobilize that thinned out clinoid unless I see that is a clinoid. It is thinned out really. If there is no aneurysm there, I will just bite it off. There is no problem at all. If it is a basilar-tip aneurysm, or if it is something that I have to take out that clinoid, I'll just bite it off. Can you see the optic nerve completely there? Everybody? Right of my field, right top.
Yes.
And now I am just drilling off the rest of the, see the bone is mobile. That bone is mobile. And between the optic nerve and the carotid, now what I'm drilling is the strut. Okay, that is the only portion which is non-mobile now. So I am now mobilized. See, you can see the carotid optic junction now, extradural optic nerve. Now I'm using a 1 millimeter, okay, to take out the remainder of the clinoid. And you can see the reddish, under the optic nerve, you can see the reddish dura, which is the aneurysm. Can you see that? Can you see the reddish dura just right of where I'm drilling? Can you see the reddish dura? And that is aneurysm. When I open the dura, you will see that is aneurysm. Okay, that is aneurysm. I am drilling the bone lateral to the aneurysm. Can you guys appreciate the optic nerve? And below the optic nerve, the aneurysm, and my 1 millimeter drill taking off the bone, which is the clinoid lateral to the aneurysm. You will see that once I open the dura, you will see the aneurysm and the optic nerve, how its relation is now. There's no force at all. It's just painting it out. Okay, just painting it out at very, very high zoom. Now, once you've taken out everything, see that 1 millimeter drill is like a needle. Okay, if you're not careful with that, that 1 millimeter needle will just go through. So you got to be very, very careful. It can easily, even if though it's diamond, it can easily puncture the dura. Okay, we are under extremely high magnification. You can see the optic nerve is almost half of my field. Can you see that on the right side? Everybody?
Yes.
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 Almost half of my field. The extradural optic nerve is almost half of my field. And now I'm taking off the little, now below the optic nerve, you can see that red dura thinning, and that is aneurysm there. And I'm taking off the strut, the remainder of the strut I'm taking off. And just anterior to the strut is the carotid. Further drilling, thinning out, and taking off that strut here. So that area has to be completely free. Now I'm going to open the dura. And as soon as I open the dura, you will see how the optic nerve and aneurysm is related. Here we open the dura. And can you see the optic nerve now? Yes?
Yes.
That is
Yes.
optic.
Yes.
Can you see the aneurysm? Lateral to the optic nerve is the aneurysm. Can you see that?
Yeah.
Yes.
So if you had not done your extradural clinoidectomy, you know, the clinoid would be projecting out there and you will have had a lot of problems. Huh? So that is aneurysm. Okay? That is the aneurysm. That's a transitional aneurysm. So how are we going to tackle this now? So obviously I'm going to do some arachnoid dissection here. Open out there. You can clearly see the optic nerve now.
I'm really sorry, but I saw that you are not using the irrigation while you are using the drilling in this area. Is that safe here to use the drilling without irrigation?
Yeah, see, you must understand one thing. Here I'm using a 1 millimeter drill and my field is so magnified that if I use a little bit of irrigation, I can suddenly lose sight. And plus, you must also know that here my drilling is not really drilling, it's just painting. I'm not using any force at all. So that bone getting even white is, you are not going to see it. And the moment I drill a little bit, maybe about for 5-10 seconds, I'm going to stop and I'm going to irrigate again and I'm going to go ahead. So it is, yes, your question is right. Using irrigation, using without irrigation is not at all safe here, especially near the optic nerve and over an aneurysm. It is completely unsafe. But here the magnification is so high and the force on the drill is almost nil. That is what you have to understand. Okay. Right.
Thank you.
Not at all. See, now you are going to dissect there. Right. So the optic nerve is dissected now. So what I'm going to do is, what is the ligament? What is the dura over the optic nerve? That dura over the optic nerve, what is it called? Do you know?
Falciform.
The falciform ligament. So I'm going to cut the falciform ligament now. Okay. I'm going to cut the falciform ligament. And you know what? The falciform ligament becomes what? Do you know it? The falciform ligament hugs the carotid. Hugs the carotid as what?
The distal dural ring.
Distal dural ring.
Absolutely. The distal dural ring. So I am cutting the falciform ligament Yes, and I am cutting the distal dural ring. When I come to over the top of the carotid, I am cutting the distal dural ring. But in this aneurysm, if I have to get it, I have to cut the distal dural ring for sure. And then you see, I'm using a hook and I'm under very high magnification. And of course, I'm using it. I'm cutting the distal dural ring. There is no clinoid here. That is the beauty of this, okay? There's no clinoid here. If there's no clinoid, see how easy this aneurysm is now. And now, what am I cutting? What am I cutting?
It's
Anybody?
proximal. Not clear.
Yeah, this is not very defined. This is the proximal dural ring is not very defined actually, but the distal dural ring, proximal dural ring junction laterally is almost into the carotid. So you must be very careful when you cut there, okay? You must be very, very careful when you cut there. Now I can get this aneurysm because I have the carotid, I have the optic nerve, and I have the aneurysm. So I know how to clip this aneurysm. You can see the C3 carotid. When I am going to clip this aneurysm, you can see the C3, that is the paracella carotid below the proximal dural ring. You can see that. You will see that now when I'm going to clip, okay? So I have this aneurysm completely. I'm not going to cut the proximal dural ring because it is going to create a lot of bleeding because that's, that is the roof of the cavernous sinus. And I will show you some of the other videos where we have to really cut the proximal dural ring. But here partial cutting is enough. You don't need to cut the entire thing. So the clinoid is completely not there. The strut is completely not there. So it is very, very easy for this aneurysm to be clipped now. This entire aneurysm is exposed and we're going to put the clip in now. You can see the normal carotid there. Can you see the carotid there? Yes, everybody?
Yeah.
Yes.
That is the carotid, okay? Now I'm going to put in the clip. One limb of the clip is going parallel to the carotid there into the C3 carotid, okay? And one limb is this side. So you're going to put that clip there. You know, you don't get that angle somehow you don't get an angle with this. Can you see the C3 carotid going down? Can you see the C3 carotid going down? Medial to my clip. Can you see the C3 carotid going down? Yes?
Yeah, under the optic nerve.
Yes, under the optic nerve. Beautiful. Okay. But I have a dog ear now, and that dog ear has to be taken by another clip. Okay. So away from the carotid, and that dog ear is taken now, and that is a carotid reconstructed. And yes, right. So let me stop broadcasting. How do I get back to Zoom? Yeah, okay. Right. So I hope all of you saw that. Yes, everybody saw that?
Can I ask a question?
Any questions now? I think is Professor Goyle here?
I don't see him, Mike.
You haven't seen him?
No, I've sent a couple of emails, but I don't know what's going on. Maybe the internet's down there.
John, I'm with you, my dear friend.
Oh, there you are. Okay, good. You snuck in.
What name have you logged onto, sir? I mean, is it some different name that you have logged on under?
AG. AG, under a pseudonym.
Oh, I see, AG. I got it. I was looking for you, sir. Okay.
So no, I saw your beautiful I must, these are difficult problems. These are not simple aneurysms to do. And you did it with great confidence and with great beautiful expertise. You did this aneurysm. I saw And I'm sure this kind of aneurysm requires a lot of dedication, commitment, and understanding of anatomical concepts, and going to the anatomy lab, working with the cadavers, working day, night. These are not easy problems, as you know. And you have to know when the problem becomes difficult. You have to know how to handle when it bleeds. You have to know where to get the proximal control. You should know where the third nerve relationship is. Do you know which is the cranial nerve which can be affected whilst drilling the anterior clinoid process? The most common is not optic nerve. You can damage the third nerve. And there are
Absolutely.
various issues. You see, these are difficult. Life is not easy when you are doing complex cases, and you know it very well. And those who are watching must know that this is not such a straightforward, simple thing. You have to work hard to get to this point, and you have to dedicate your life. This is not 1 day affair or 2 day affair. This is a lifetime affair to remove the anterior clinoid process and to get to the internal carotid artery and the aneurysm. I really enjoyed the operation. Congratulations.
Thank you, sir. Thank you, sir. Over to you, sir. Now over to you, sir. I mean, we'll watch your show now, sir.
Okay. Now, you know what? The main thing is, let me just get my slides on.
Yeah, perfect. Perfect.
You know what? Cavernous sinus surgery is not easy. Cavernous sinus surgery is not easy today. And believe me, it was not easy 35 years ago when I actually landed into this field of cavernous sinus. And Vinko Dolenz was one of the very big stars of the cavernous sinus surgery. At that time, Laligam Shekhar was a young man entering into in a very big way. Of course, there were other stalwarts like Sami and various. Hakuba was a big man at that time. 35 years ago, cavernous sinus surgery was actually not there. And Vinko Dolenz removed the anterior clinoid process, and he became instantly very famous. Everybody in the world wanted to do skull-base surgery at that time. Skull-base surgery indeed was an absolutely a big fascination for young people and for everybody in neurosurgery. So I am going to talk to you about my personal historical perspective over the period of last 35, 37 years and my love with this subject of cavernous sinus. It is a small area, but I have lived in this area all my life. And as I was mentioning, you have to know absolutely the anatomy of cavernous sinus, the anatomy of dural rings, the anatomy of dura. And I am going to talk to you about some of the concepts that are absolutely crucial. And I have to also mention before I start that all the things which I will talk are my own concepts and own published concepts. So I will base on my perspective on cavernous sinus. How I have viewed this subject in the last 37, 38 years of my neurosurgery, and how I have developed this field of cavernous sinus surgery. So in 1996, this book of mine was published with Professor Kobayashi. In 1996, if you have an opportunity, this book was published by Churchill Livingston. And if you have an opportunity to look into this book, this entire book, my part of the book is completely my own work. There is no other reference from any other author in the book. The whole book has my own personal references. So this was my book in 1996. And you see how this exposure that you see on the cover page. And I showed you some images the other day. You see, I was in the business of drilling the petrous bone, in the business of handling the carotid artery, in the business of handling the facial nerve, in the business of cavernous sinus, in difficult zones. So that was I began my life in this field in a very big way. And I must tell you that I have enjoyed my entire business with this cavernous sinus in so many years. And I have published, many of you have seen my publications. And as I mentioned, I will base my entire presentation on my own work and my publications. Cavernous sinus as an entity was completely not understood. There were not a single article in the literature saying as to what is the function of cavernous sinus. Is cavernous sinus that venous dilatation in the skull base, does it have some meaning, or it is just an anatomical kind of a structure? I have to tell you that there is no terror of error in nature. There is not a single entity in the anatomy of the skull base or brain or any part of human anatomy which has no function. So we had, at that time, you see this article of mine was published in 1996, a speculative note, and there are subsequently many articles of mine on this subject as to what is the function of cavernous sinus. If you see this title, cavernous sinus and its role in eye movements, we all know what is the role of the sixth nerve. We know what is the role of fourth nerve. We know what is the role of third nerve. We know the optic nerve has the function of vision. But do you also know that the cavernous sinus also has a role in vision? Cavernous sinus also has a role in eye movements. So this was a very beautiful article of mine, and I wish some of these articles which convey the message as to what is the function of cavernous sinus. And we, in our articles, we have said about various issues about the function of sinus. For instance, do you know that this is the deer, and this slide of mine was my first presentation of this slide. This is my historic slide. And first time I used this slide in the year 1992, 28 years ago. Do you know the cavernous sinus of a lion is smaller than the cavernous sinus of a deer? And Hakuba also had a very big contribution in this field about fish cavernous sinus and other things. So we identified that the cavernous sinus of a lion is much bigger than the cavernous sinus of a deer is much bigger than the cavernous sinus of a lion. See, when the deer runs, it has to look in front and jump. And also at the same time, it has to look behind towards the lion. How far is the lion, and when the deer has to run faster. And so it has to look in front and look behind. So the eyes are located laterally in the lateral part of the head. So it has to look in front, look behind. So eye movements are very brisk, like zzz, completely front, behind, front, behind. So the eye movements are very brisk. On the other hand, the lion, when it runs, it has to look only at the deer to jump and to catch hold of the deer. So the eye movements are not so big. So we speculated that because the eye movements are not big, there is no need for a big cavernous sinus. So cavernous sinus provides a very big drain off. When the eye moves laterally, cavernous sinus, there is venous drainage in the cavernous sinus. When the eye looks front, the cavernous sinus, the venous drainage is not there. So this is what we had speculated, that the eye movements are regulated by cavernous sinus. And also we referred to one very beautiful thing, like cavernous sinus also has a role in vision. When there is cavernous sinus thrombosis, third nerve weakness, develop eye movement restriction. Even when the sixth nerve is present, even when the fourth nerve is present, even when the third nerve is present, you get, so we speculated, these are speculations or philosophical understanding that when the venous sinus is not there, the eye movements are gone. So venous sinus has a role in eye movements. Even at the later stages of cavernous sinus thrombosis, there can be vision gone. So we speculated that cavernous sinus has a big role in vision. See, cavernous sinus is a hydrodynamic system. Water. Eyeball is the king of hydrodynamics, eyeball itself. There is vitreous humor in the eyeball. Just a minute. I will talk about eyeball later. So cavernous sinus is a very small anatomical space, and it has troubled the neurosurgeons for a long time. And many of the tumors occupy the space within the cavernous sinus or outside the cavernous sinus. Sinus is right in the center of the skull base. Tumors may not occupy the cavernous sinus, but they are in the vicinity of cavernous sinus. So we should know the anatomy of cavernous sinus if we are going to operate in the vicinity of cavernous sinus. Cavernous sinus has internal carotid right in its substance. The sixth nerve is right, the course of sixth nerve is right within the substance of cavernous sinus. This is the third nerve, this is the fourth nerve, this is the fourth nerve, this is the V1 division of the trigeminal nerve, this is the V2 division of the trigeminal nerve, the V3 division is outside the confines of the cavernous sinus. This cavernous sinus has two intercavernous sinuses which communicate with each other. The more important relationship of the cavernous sinus is with the sphenoid sinus, with the paranasal sinuses. So we had speculated in my article that cavernous sinus, this relationship of cavernous sinus with the sphenoid sinus or with the paranasal sinus has a big role in the temperature regulation. Do you know when the air goes in the nose, it remains it may be cold or hot, but as soon as it passes the nose in the trachea, the temperature becomes normal temperature. Similarly, when you drink or eat hot fluid or hot material, the mucosa of the mouth is the most vascular structure of the body. As soon as the food goes beyond the mucosa, beyond the mouth in the esophagus, the temperature becomes normal. The mucosa, which is the most vascular structure, has a role in regulation of the temperature of the food. Similarly, the relationship of the mucosa with the cavernous sinus, we speculated that it has some role in the temperature regulation of the body. You see, this is the sphenoid sinus. There is mucosa here. This mucosa gives information about the temperature of the body or temperature of the external temperature to the cavernous sinus. This cavernous sinus gives information to the pituitary gland, and the pituitary gland, then the master gland, regulates the whole body. These are speculations. Similarly, we speculated that the carotid artery, which comes in a kind of a loop within the cavernous sinus, it runs in a in a quite a haphazard manner, in a multiple loops, and that gush of fluid, when it goes in cavernous sinus, has a role in the monitoring or changing temperature, and it gives information to the cavernous sinus about the temperature in the body, and that information goes to the pituitary gland and it regulates the rest of the body. So this is one of the speculation. In similar fashion, we had made several speculations about what the function of the cavernous sinus might be in the control of blood, in cerebral blood flow, in the cerebral temperature, in the body temperature, in controlling the pituitary gland, in controlling the eye movements, in controlling the vision. The Hakuba has good contribution in the understanding of cavernous sinus of a fish. Do you know cavernous sinus also has some fat component within the confines? This fat is more predominant in a fish. In humans, also there are fat lobules within the confines of the cavernous sinus, but the fat is much less as compared to fish. The fish, the eyeball of the fish is located laterally over the head. So we had speculated that the eye movements are so big in the fish that it not only controls the eye movement, this cavernous sinus, but it also takes a part in swimming, in balance. Do you know what will happen if you puncture the eye of the fish, one eye of the fish? The fish will immediately stop swimming and it will sink into the bottom and it will die. So the cavernous sinus has a role in balance of a fish, role in eye movements. Although that role is not so much prominent in human beings, but you know, when you talk about Romberg sign, you close the eye, you lose your balance. Although we talk about vision in the control of balance, but cavernous sinus may also have a big role in your balance. So this is what we had speculated. So these are the eyes of various animals. And this animal you know very well, this is a human being. The beauty of the human being lies not only in the eye. We say what it is not the eye, but what lies behind the eye makes you beautiful. We normally talk of your brain when you talk about beauty and brain, but what lies in the immediate vicinity of the eyeball is cavernous sinus. So cavernous sinus determines your beauty. This is what we had speculated and mentioned in our articles. The other thing is, you know, this eyeball is a hydrodynamic system. It is the height of hydrodynamic system. There is aqueous humor, there is vitreous humor, and there is lens. All these are fluid filled. Do you know if the fluid in the eyeball becomes in higher pressure, you will develop glaucoma and severe pain. If your fluid in the eyeball is little bit less, your movements may not be there. Your lens has to be in perfect shape throughout the life, or else you will need glasses or your vision may go. And there is a communication of this venous complex of the eyeball through the retinal artery, which has no muscular layer. So this communication of this hydrodynamic system, retrobulbar fat is there, which is also a hydrodynamic system. If you press your eye, you see, if you press your eye, immediately the pressure will be transmitted to the cavernous sinus, and that pressure will be transmitted to the contralateral eye. For some time you will have diplopia, and then that diplopia will disappear because this fluid in the both sides are like pressure management system. So what is important is the beauty of your eyes. You see the beauty. And what lies behind your eye is the cavernous sinus. You should not underestimate the intensity of the function of cavernous sinus. And those who want to know more about my speculation should go into my multiple articles, which I have shown here. And of course, this presentation will be recorded and you can see those articles and go to my articles. You must also read several of my publications which are based on the anatomy of the cavernous sinus and techniques which are based on anatomy. As I mentioned the other day, extradural approach to tumors involving cavernous sinus. This was the first article in the literature. That does not in any way diminish the great contributions of Vinco Dolenz in developing an extradural approach to aneurysms of cavernous sinus. And Vinco Dolenz is I have got a very personal friendship with Vinco Dolenz for a very long time. And this contribution of mine is based on his contributions on vascular anatomy. And now what I'm going to show you is the anatomy of cavernous sinus as it relates to cavernous hemangiomas. I am going to talk to you about the medial compartment of cavernous sinus. Some of these things I have talked to you the other day when I was talking to you on trigeminal neurinoma, when I was talking to you on pituitary tumors, when I was talking to you on other tumors. So I will be repeating those. So some of these, how the arterial relationships of the cavernous sinus can impact your understanding of surgery of cavernous sinus. This article was written 22 years ago, and believe me, my young friends, 22 years ago, cavernous sinus surgery was just being born. This article of mine was written in 1997. Cavernous sinus surgery was just emerging. MRI came into the picture of neurosurgery in 1987, 88. At that time, we understood the anatomical concepts of various regions during that time, and that so many of these articles of mine are during that time. Infratemporal approach to trigeminal neurinomas, and I will talk today about chondrosarcomas, one of my very favorite articles published in 1995. And I will also talk to you on cavernous hemangiomas of cavernous sinus, one of the most difficult neurosurgical problems. We describe extradural approach to these tumors for the first time in the literature. There are several more articles on various tumors, on clival chordomas, on angiofibromas, on pituitary tumors, on pitoclival meningiomas, and things like that. And these lists will be on the internet. You can get these articles, and if you are interested, you must read. And if you are listening to my presentation, I'm sure you are interested in my work, and you must go and read these beautiful articles which were having quite an original contribution in this field, and which some of these contributions I'm going to talk to you today. Aspergilloma involving the cavernous sinus, epidermoid cyst involving the cavernous sinus, teratoma involving the cavernous sinus, hemangiopericytoma involving the cavernous sinus, fungus involving the cavernous sinus, dermoid cyst, and things like that. Epidermoid tumor, hemangiopericytoma, aspergilloma involving the cavernous sinus. I am going to show you some of these cases. If you read my articles and read my various articles on the subject of cavernous sinus, you will be surprised that most of my work is based on the concept of dura, based on the concept of membranes. There are at least 50 articles of mine where I have said that dura is respected by the tumor. And on the basis of this respect, I have shown how the surgeon can respect the membranes during the surgery. You must know that membranes come first, bones come later. Mandibular nerve does not pass through foramen ovale. It is the foramen, the bone of foramen ovale, which develops around the mandibular nerve. Internal carotid artery has a very intense relationship with anterior clinoid process, but it is internal carotid artery which comes first. Anterior clinoid process comes late in the embryological development of a human being. Bone development is an afterthought of nature. Bone comes later in the embryonic life. The entire soft tissues are born before even a spicule of bone is born. So dura comes much before any bone comes. Bone comes later. Dura is the strongest part of the membrane. It is like dura is durable. The blood vessels of the skull base, the nerves of the skull base respect the dura. That is what my concept is, like what you were seeing today, the dissection of the dura. And you asked Dr. Ipe whether the aneurysm is going to rupture the dura. And he answered no, because the dura is durable. You see in aortic aneurysms, how the aortic aneurysms will grow big and big and big. They will destroy the bone, but they do not destroy the dura of the spinal cord, which is displaced. It can never go beyond the dura. If you respect the dura during surgery, and if you know how to respect the dura during your drilling, you can do a lot of neurosurgery safely. And that is what I'm going to talk to you today. So as I mentioned to you, I work in a public institute, KEM Hospital.
It looks like a slight delay.
Yeah, John, let's hang in there.
Yeah, he dropped off the screen, I believe.
Yeah, his slides are still seen, I'm sure. We'll just hang in there, okay?
Okay.
He'll come.
Okay. You want to talk about that slide, Ike?
This one?
Yeah.
Well, no, I mean, it's his slide. I mean, let him talk about it.
Okay.
Well, if it takes a lot of time, then I can take any questions about what I showed previously. So if there are any questions about that, I can take that. Maybe by chat, if anybody can type it in, I can answer that. But let's wait for Professor Goyal to come in.
John?
Yes.
I am on my phone. I cannot show the slides, but in the meantime, I can answer questions. I'm connected with my phone.
Oh, you're connected with your phone? I think you have to leave that screen share first. You're sharing the screen with something, so just get off that screen share. Okay, now you're back at square one. Now, what did you want?
Okay, now I'm almost done. Okay.
Okay. Should be able to share now.
Okay, John.
There you go.
Are you with me?
Yeah, that's it. The CT showing. Okay.
So what I'm doing is, I'm giving you some break so that you can relax in the meantime, because this may be a little bit heavy stuff. Now, what I'm working in this AM hospital since 1982.
Sorry, I think there is an echo.
Hospital. My advantage for me was that I was involved in very heavy workload. And for 24 years, I'm head of this department of neurosurgery in KEM Hospital, which is one of the biggest public hospitals. So that gave me a very big advantage and a platform to do very complex cases throughout my life. You see, this case I had done in 1993. And you can imagine this tumor removal. And at that time, there was no recording as such, but you can see the whole petrous bone has been removed and this tumor has been completely removed. I will show some of these tumors at a later date. You see the basilar artery is involved, opposite carotid artery, opposite ipsilateral carotid artery, and this was a meningioma. John?
Yes.
Has he dropped off again?
Yes, he did.
Yeah, I am on the phone now. I can talk in the meantime.
Okay, no problem. Maybe let the guys, let them ask.
It is good. It is.
So you can take
Yeah,
the
if there are questions, I can answer in the meantime.
Yes, absolutely. All of you, please go ahead, ask, sir, whatever questions are there, please ask. You can either chat or ask the questions.
See, cavernous sinus is quite you have to spend a lifetime in cavernous sinus. You have to work hard to learn this subject. Anatomical dissections are very, very important and critical and crucial. You have to know exactly the anterior clinoid process, the posterior clinoid process, the intercavernous sinus area, the internal carotid artery area, how the third nerve enters into the cavernous sinus, how the sixth nerve enters the Dorello's canal. You have to know exactly how it is where it is landing in the cavernous sinus. You have to know how the carotid artery loops into the cavernous sinus, the sympathetic plexus, how it travels along the cavernous sinus along the carotid artery into the cavernous sinus. You have to know the sympathetic ganglion within the cavernous sinus. And you have to know there are fat lobules Most important thing that you have to know is that all the cranial nerves in the vicinity of the cavernous sinus have a very thick dural cover. No cranial nerve in the cavernous sinus is exactly loaded with blood around it. So it is not that blood directly touches the cavernous, the sixth nerve. Blood does not directly touch the fifth nerve. Fifth nerve is within its own dural confines. Similarly, the third nerve does not directly touch the venous blood. So this we have to know.
Atul, are you there? I think we lost him, Mike.
He's still on the phone, I guess.
Okay.
Yeah, I am on the phone.
Okay.
It is not, it is taking time, unfortunately. Like, unfortunately, I have to work from my house. The connection is not
No problem,
great.
sir. No
And
problem.
it happens, when it happens, it will be continuous. Like I could see Ive's presentation continuously without any. So it will come. So what I'll do is I'll just time. The other thing that all the young neurosurgeons who have to enter into the business of cavernous sinus have to know how to drill, how to use cutting, to use diamond burr, when to use big burr, when small burr, and you have to work under bleeding situation. Most important thing is when you are dealing with tumors, you have to know how to break the tumor, how to learn the art of breaking tumor. If you continuously keep on coagulating within the confines of the tumor, it may not be the best form of tumor resection. Some tumors have to be broken. Some tumors have to be dissected from the circumference. Which tumor has, all tumors have a very unique pattern of dissection. So that's very important lesson experience. Pituitary tumors are different. Trigeminal neurinomas are different. Hemangiomas are different. I am going to show you some hemangiomas also. Meningiomas are different.
You cannot compare between the bleeding during.
I'm sorry, let me get that. Okay, sorry.
So you have to control the bleeding during tumor resection. You have to avoid blood and continue your tumor resection. You have to the blood and dissect. So there are various resection which you have to learn if you have to do complex surgery. On the other hand, if you want a completely clean field during your tumor resection, that is a good way of doing tumor resection. But many of the tumors in the confines of cavernous sinus, you cannot do it. If you say, I want a completely clean field, bloodless field, you cannot. You have to learn how to break into the tumor. You have to learn how to respect the dura and the membranes, and you have to learn how to do the tumor dissection, and you have to proceed in the dissection. I'm unfortunately not yet able to enter into the field of. So what I'll do is I'll wait for your questions. You have an answer by the time my.
Sir, I can show another rupture, sir, paraclinoid rupture or something, sir.
You can start. I think that may be a good idea.
Yes, sir. But as soon as you get your connection back, I will stop it, sir.
Okay. That is a good idea. Please.
Yes. So I will share now, sir.
Yeah.
John, I am sharing now.
Okay.
Okay, can you see my screen?
Yes.
Okay, this is another aneurysm. So this aneurysm is again another transitional aneurysm, but this ruptured. So you can see the aneurysm clearly now. This is on the right side. You can see the right side aneurysm. So that is aneurysm there. Same thing we are doing. We are doing the orbitomeningeal band dissection. Is the right side temporal lobe. I am slowly retracting away. And the orbitomeningeal band is being cut now, parallel to the superior orbital fissure. The same thing like last time. So we are slowly cutting and going parallel to the superior orbital fissure. So you can see my section is parallel to the superior orbital fissure. You can see the cavernous sinus behind the superior orbital fissure. You can even see the superior orbital fissure entry, and I am taking off all the bone there. So we are going on removing using a 2 millimeter drill there. What Professor Goyle was talking about the drilling, very true. It's you have to know the pressure of the drilling at each time that you're drilling. So at very high magnification, you need extremely low pressure. So all that drilling done. The Kleinoid process is being cored out gently. The right side. The optic
I am
root.
ready now.
Yes, sir. I'm stopping, sir.
You continue.
No, sir. No, sir. No, sir. I'm stopping now. Stop, sir.
Go ahead, Dr. O'Toole.
Yeah. Okay, can you see that?
Not yet. You still working on it, O'Toole? I think he's still working on it. Are you there, O'Toole? He may have slipped off. He may have slipped off again. Do you want to continue or?
Yeah, I can continue. Is he on the phone?
O'Toole, are you there? I think he slipped off.
Okay, the moment he comes back, I'll stop it.
Okay.
You're seeing my screen?
Yes.
All right, so we are drilling off that clinoid. And now you can see the optic nerve there, medial to where my drilling is going on. You can see the optic nerve roof is completely unroofed. And I am drilling away the strut now.
Roof மேல இருந்து approach பண்றான்னா இது intracranial.
Somebody's having fun. Okay, right. So my suction is on the optic nerve roof. Now I'm opening the dura. I wanted to show you how intradural, extradural drilling is done here. So now you can see the carotid there, the optic nerve there. My suction is over the optic nerve. I'm opening the dura. I'm opening the distal dural ring now. And once I'm opening the distal dural ring, and then I need to drill bone now. This is because I did not go after the strut like I did in the previous case. So you see, the preference of intradural, extradural versus extradural drilling is your preference whether you want the hard part first or the hard part later. So you can prefer, you want the hard part first, then you can do the extradural clinoid drilling first, and then do the clinoid, then do the carotid without any drilling. Then do the aneurysm without any drilling. You want the hard part in between, you can do some extradural drilling, and then like this over the aneurysm. The aneurysm is right there. The dura is open, and I am now drilling the strut. The strut and the lateral part, I'm drilling now. So under very, very high magnification, I'm drilling the strut. This is also possible. The aneurysm is millimeters away from me, and there is no dura here. There is no dural protection for me here. But if the aneurysm ruptures here, I know that I can clip it because it's all exposed here, and I can put in a distal clip and I can go ahead and put a clip. But obviously, I don't want to rupture the aneurysm with a drill. That would be not pleasant. Then, of course, we are looking at a bypass. So we are keeping on reducing the strut. This is side drilling. So last time we did complete extradural drilling. Now we are doing a hybrid drilling, which is most extradural and a little bit intradural. Only thing is the dura is open and the aneurysm is right there. You can see I'm reducing, keeping on reducing so that I'm going into the roof of the cavernous sinus there. As I drill, I'm going into the roof of the cavernous sinus.
Excuse me, Atul is back.
Okay, I'm going to stop now.
Okay. Go ahead, Atul.
Okay.
Okay, I have stopped.
Yeah, okay. Atul, are you ready?
Yeah.
Go ahead. Okay, we can see it.
Yeah.
Okay, now you can see.
Yes.
Yes.
Okay, I'm sorry for this unbelievable connection, but I am completely under quarantine and I cannot go out to the department where the computer is better and internet is better, but we have to make the most of it.
So there is an echo. You are probably speaking through the phone also.
As I was mentioning, we have to be very good in the drilling, and we have to be good in the philosophical understanding of the tumor. And I was mentioning about bleeding during the tumor resection. We have to be master of that situation. Fortunately for me, I have been dealing with blood throughout my life. whether I have cavernous
Sir?
sinus, whether I will be travel.
Sir?
Yeah, excuse me, excuse me, a tool. I think you have another,
Beautiful advantage.
I think you have another device on, the tool.
1995, which is also part of my book.
John, can you mute one of it?
Many
I can try, hold on.
The question is,
Give me a second.
remove it, or you know, whether you don't want to touch these tumors, because they are indeed dangerous. If you do,
Good, right?
in 1995, 25 years ago, I had done this case. There was a small residue at that time, and no radiation was given, and this residue remained for a very long period of time, and this patient also remained in a quite a fantastic clinical condition for a long time. This was one of my very high profile patients early in my career. During that time, if you get a high profile patient, you were very proud. So this was one high profile patient. So meninges are the mother of brain. This has been my principle, and this has been my guiding force. Another beautiful one or two sentences I want to give you is that brain is nothing but sunken skin. And this is the 1996, my article on extradural approach to cavernous sinus, to the tumors involving the cavernous sinus. You see, this is the cavernous sinus. You can remove the dura like this. Then there is dura along the cranial nerves. And then there is another layer of dura. And then you come inside the cavernous sinus. And then there is another layer of dura around the sixth nerve. So you cannot damage the sixth nerve very easily unless you are using cauterization, unless you are using very firm, sharp dissection around the sixth nerve. The sixth nerve is very well protected. And there is also a very beautifully defined dural membrane around the carotid artery. So there is this cavernous sinus surgery is the game of dura, game of membranes. And as we saw in the dissection of anterior clinoid artery in that region of aneurysm, it is the game of respecting the dura. So this was my article on how the tumors respect the dura and how the arterial relationship of the tumor will determine which tumor is this. This article we mentioned that on the basis of relationship of the tumor, you can identify the histological nature of the tumor. When the tumor encases the cavernous sinus, does not squeeze the cavernous sinus carotid artery, it is a different tumor. When it squeezes the carotid artery, it is a different tumor. It is a different consistency of the tumor. When it displaces the cavernous sinus, it is a different consistency of the tumor. So on the basis of the arterial relationship, you can identify the histological nature of the tumor, and you can plan surgery. So this was my very old article, and those who will be interested must read this article. Now, I don't want to interrupt, but I want to ask the panelists as to what is this tumor? What do they think this tumor is? And this tumor I had done in 1991. I can give you some guesses that this tumor is the most vascular tumor that you will ever see in neurosurgery. That is one. Second guess is this is the most benign tumor of the body. And this is completely within the confines of the cavernous sinus. So this is a cavernous hemangioma of the cavernous sinus, the most benign tumor of the body, more benign than a meningioma. And this occurs within the confines of the cavernous sinus. In the year 1991, I removed this tumor before there was, I am not sure if there was any article in the literature before 1991 which showed a complete tumor resection of cavernous hemangioma. And also we described in our article in 1991 the dural relationship of cavernous hemangiomas. So cavernous hemangioma is one intracavernous sinus tumor. It remains within the dural wall of the cavernous sinus. It goes near the orbit. It goes near the Meckel's cave. It goes near the near the pituitary gland in the intercavernous sinus. The entire tumor is within the confines of the cavernous sinus. No matter how big this tumor becomes, it will never go beyond the confines of the cavernous sinus. I will show you some tumors today, but I will make a separate presentation on cavernous hemangioma in one of my lectures. So cavernous hemangiomas are within the cavernous sinus. Carotid artery lies within the cavernous hemangioma, and you can also realize the sixth nerve lies within the confines of this tumor. Many of these tumors come with the only symptom of headache. Now, whether you want to operate this very vascular tumor wherein you can actually damage the sixth nerve, you can damage the cranial nerves, and you can damage the internal carotid artery. It is a vascular tumor, bleeding. And I must tell you, those who like coagulation at all times should not do these cases, because this will be a bloody situation. And if you want a completely hemostasis and going, you will not be able to ever remove this tumor. And if you will go on coagulating, you will certainly damage the sixth nerve. So you have to learn how to remove a cavernous hemangioma within the cavernous sinus. And I will show you some videos in my subsequent lectures. So when you actually go, you must know that this tumor is within the cavernous sinus, and cavernous sinus is an extradural entity. And for the first time in the literature, we described an extradural approach to these tumors. Now, there are subsequent many articles on this subject, and I have not seen anybody who will not use this approach. Whether they mention my paper or not, that is different. But this was the first article in the literature which mentioned that extradural approach is the only approach for cavernous hemangioma of cavernous sinus. You come extradurally, you remove the anterior clinoid process, or you don't remove the anterior clinoid process. You have to go inside around the tumor for a period of time, identify the sixth nerve early in the operation, keep the sixth nerve safe from the tumor, and then remove these tumors. So extradural approach, understanding that these tumors respect the dura, these tumors will be within the dural confines. That is the bottom line of surgery for cavernous hemangioma of cavernous sinus. So that for these extradural tumors or intracavernous sinus tumors, this is the only approach that is most philosophical. This is what we had discussed. This is another cavernous hemangioma of cavernous sinus. You see, it is going in the intercavernous sinus towards the pituitary gland, but there is a well-defined dura here. This tumor goes in the intercavernous sinus, you must know this. And this tumor goes near the orbit, near the orbitus apex, near the Meckel's cave, but not the fifth nerve components. The fifth nerve is not directly in contact with this tumor. The third nerve is not directly in contact with this tumor. So this kind of radiological impression you must keep in your mind. And when you see such a radiology where the tumor is going towards the pituitary gland, it is going towards the orbit, it is going towards the Meckel's cave, it is encasing the internal carotid artery. It is only one tumor that can do this, and that is a cavernous hemangioma. If you mistake it for a pituitary tumor, you can land into very big problem. My first tumor, which I showed you here, this one, I had mistaken it for a pituitary tumor. And we had removed first, we came from the transnasal route, and there was a huge bleeding from this part of the tumor, and the histology came as cavernous hemangioma. Then I went and did this tumor from a regional operation at that time. And that time I was not knowing about the possibility of removing this tumor extradurally, and we had a very big exposure at that time in 1991, and I had published this paper. And as I mentioned, there are not many, before 1991, not many cases of radical total resection of hemangiomas. Now, when to do this operation, when not to do this operation is a very big thing. Now this girl, this tumor, and this patient had come with a third nerve palsy here. You see the eye movements are restricted, and following surgery, you have brought a smile on this patient's face. More important presentation is with headache. Many of these patients, this tumor usually occurs in young children, not children, but young adults, like this lady, and you can actually give a beautiful new life. And radiation treatment, recently some people are talking about radiation treatment for cavernous hemangiomas. During that time, no radiation would ever work for cavernous hemangioma. Many people still think hemangiomas of cavernous sinus radiation will not work. So there is a possibility of giving back movements to the eye. But also I must tell you that the patient may come with this kind of situation and you may give this kind of eye to the patient. You completely demolish, so that remains a possibility. And also I have to tell you that there can be a big internal carotid artery rupture during the operation, and then you have to do various kinds of maneuvering. And as I mentioned, I'm going to give you a separate lecture on cavernous hemangioma of cavernous sinus. Today, I'm going to just give you philosophy and dural relationships of these tumors. Then I had talked to you about pituitary tumors and how they respect the dura. And this article also of mine, as I mentioned the other day, has some concept which are completely revolutionizing concepts about the dura. I said that the dura of diaphragm is elevated by the tumor, dura of the cavernous sinus is displaced by the tumor, despite the fact that there is a nubbin here, but this nubbin, there is a dural presence around the tumor that you must know. And if you do not know this concept, that the dura is going to be around the dome of the tumor, you cannot remove these pituitary tumors. Dura of the cavernous sinus, when it goes, as I've showed you the other day with many slides, many images, that it enters the cavernous sinus, but the dura remains intact. And we have to remember this dural relationship. It can go in both the cavernous sinuses, but the dura remains intact, dura remains intact, and the dura remains intact. This concept of dura was not in the literature 25 years ago. This, that the diaphragm will remain intact, the dura will remain intact, was not in the literature. And there is various kinds of discussion in the literature. The dura will bulge of the diaphragm, dura of the cavernous sinus will bulge, but it will not be transgressed. This anatomical dural relationships are very, very crucial. I am repeating this from my previous lecture because they are so crucial for understanding the cavernous sinus dural relationship. The diaphragm dura is intact, the roof of the dura of cavernous sinus is intact, the lateral wall dura is intact, and this relationship has to be understood. The roof of the dura of cavernous sinus is intact, the diaphragm is intact. When the dural roof is elevated, I call it grade 3 tumors, like I had discussed with you the other day. Roof of the dura of cavernous sinus is intact. So this entire tumor is within the dura and the medial wall of the cavernous sinus. So why some tumors transgress the dura and why some tumors do not transgress this medial wall is the enigma. Also, whether the dural cavernous sinus is completely extradural entity or not, whether some part of the dura cavernous sinus is not extradural and all. There is a discussion on this subject for last 30 years. This enigma has never been solved. So this is pituitary tumor, and I showed you some the other day. Dural roof, dura of the diaphragm, dura of the roof, dura of the cavernous sinus, this remains intact. And you have to, when you have to understand this anatomy before you are planning. It is only very rarely that the dura of the diaphragm is transgressed and internal carotid artery and circle of Willis is encased by the tumor. So if you know that the dura is going to be intact, you can do a beautiful surgery, learn how to break the tumor. If you go on coagulating within the confines of the tumor, you will never be able to do this tumor. You learn how to demolish this tumor, learn how to break the tumor, learn how to enter into the tumor, and respecting the membranes, you can do a very quick job with these kind of large pituitary tumors, which I had shown you the other day, and you can give a beautiful outcome. On the other hand, if these will bleed, and sometimes they bleed very furiously, so you have to control the bleeding. The dura is going to be intact around the tumor. Dura is going to be intact in the vicinity of cavernous sinus. Break the tumor, and this is immediate post-operative. And you can imagine this tumor I had removed the year 1999. And elevating the roof of the cavernous sinus, you have to go. The thing is, you must remember that the dura is covering. If you do not have this concept, you cannot remove this tumor. And we, in our article, were the first to introduce this concept in the literature, that this dura is going to be intact, and it is extremely rare that tumor goes beyond the dura. There is method in this madness, and this madness is respected by this most benign tumor, and that is pituitary. It is very rare that So it is going to be extremely rare that the tumor will actually encase the arteries of the circle of Willis. So these are all, I'm showing you some of my publications. You must go, if you are really interested in this work, which we published on several occasions, you must, and these publications will be on the site, and you can go and see. Similarly, I described trigeminal neurinoma the other day in the year 2001, 73 cases. Now we have a series of more than nearing 300 cases. And I said that the dura of the cavernous sinus respects, they will never go into the dura of cavernous sinus, and they will never go into the confines of the cavernous sinus. They will never encase the internal carotid artery. There, in a large majority of cases, the dura of the posterior fossa is also present. So we introduced this term interdural approach, interdural location of the cavernous sinus. In a large majority of tumors, the dura is going to be present even here. And we said about this interdural approach. Dura is intact, carotid artery is never taken, cavernous sinus is never involved by the tumor, trigeminal nerve is displaced by the tumor. In a large majority of cases, the dura is going to be intact here. So this is the dural relationship you have to understand. And as I showed you, extradural approach, interdural approach to these tumors is the most philosophical approach, and we can remove these tumors even without a craniotomy, which we described in 1995. Interdural approach, I am not doing such interdural approach for cavernous sinus tumors, but just for the history's sake of history, we did this first tumor without doing a craniotomy. These tumors were considered to be very difficult during that time, and this was the basal approach that we described for large to the posterior fossa, removal of the roof of the zygomatic arch, roof of the condyle, roof of the external ear canal, and partial mastoidectomy. I do not do such exposures for trigeminal neurinoma, as I showed you the other day. For petroclival tumors, yes, I do sometimes these kind of exposure. Tumors which go extracranial are also within the dura, which I showed you the other day, and you have to respect the dura. The internal carotid artery, the hypoglossal nerve, the cranial nerves are displaced by the tumor. Similarly, I showed you that these tumors are similar to the C2 neurinomas. There is some repetition here in my presentation, but this is so critical. Many of you are young people. You will like to revise your thing. Like trigeminal neurinomas, C2 neurinomas also respect the dura. When the dura tumor becomes big, they remain within the dura. They do not transgress. They do not enter into the vertebral artery. They never encase the vertebral artery. They never encase the venous circulation in this region. We had described earlier that sometimes they go interdural here, intradural here, but in my subsequent article, I mentioned that almost 100%, even this spinal part of the tumor is intradural in location. This is the C2 ganglion in relationship to the vertebral artery, in relationship to the atlantoaxial joint, in relationship to the venous plexus in this region. So this is C2 neurinoma, this is trigeminal neurinoma, and this is my article. You note down this article and you must read this paper. So many trigeminal neurinomas I have shown you the other day, we remove by interdural approach, working within the tumor, and these massive tumors can be removed in quick time. If you love coagulation, you may have very serious difficulties. I have talked to you the other days, and I will show you some videos that many of these tumors can be removed in quick time without coagulation. Similarly, third nerve neurinoma. These tumors look very aggressive in location and very difficult for surgery. You will like to do a very extensive skull-base approach, but you must know that this is a third nerve neurinoma, and if you preserve the dura, these tumors remain within the confines of the dura. Despite the fact that this tumor looks completely intracranial, but there is a protective layer of dura around the tumor. You preserve the dura and you do blunt dissection without coagulation, you can preserve the extraocular movements. As I'm showing you here, there is not a single article in the literature where you can show that the third nerve function was preserved following surgery. And I mentioned to you other day on my series of trigeminal neurinoma, that was not a single series in the literature which showed that the function of trigeminal nerve can be preserved following trigeminal neurinoma resection. So our article was the first in the literature which showed that the trigeminal nerve neurinoma arises within the Meckel's cave, and my article is the first in the literature which shows that the oculomotor or the third nerve neurinoma arises within the oculomotor cistern. The dura covers the dome of the tumor. I am not saying that you can preserve the eye functions in all the cases, but if you think that this is the capsule of the tumor, you will never be able to preserve the eye movements. Work within the tumor confines, the dural confines, and try to avoid any kind of coagulation within the tumor, and you can preserve the function of the third nerve. Sixth nerve tumor, sixth nerve schwannoma is probably the only schwannoma which will encase the internal carotid artery. And when there is a schwannoma patient presenting with sixth nerve deficit and encasing the internal carotid artery, the diagnosis is there for you to take. Work within the tumor, preserve the internal carotid artery. Preservation of sixth nerve function is going to be a tremendous affair, and maybe it is not possible. Now I will talk to you on a tumor which is very favorite tumor of the skull-base surgeon, about the chordoma. Do you know chordomas respect the dura? Do you know chordoma is an extradural entity? Do you know chordomas will always displace the internal carotid artery? Do you know chordomas will always displace the cavernous sinus? This concept we had introduced first time in the literature about 25 years ago. And we had said that the internal carotid artery will be displaced by the tumor. We had said that the internal carotid artery will be displaced on the anterior dome of the tumor. We had said that these tumors are extradural tumor and the dura will be preserved by the tumor. These tumors will be outside the dura. They demolish the bone. They break into the bone, but they will not be able to demolish the cranial nerve. The cranial nerves, the soft tissues are displaced, and the bone is destroyed by the tumor, That is the character of chordoma. You see this tumor, this was my very favorite article that I wrote in the year 1995. Chordoma and chondrosarcoma relationship with internal carotid artery. I am not sure whether you will realize or not, but I'm sure for myself that this article was a revolutionary article in the field of chordomas and chondrosarcomas. 25 years ago, we said that chondromas and chondrosarcomas displace the carotid artery along the anterior border of the tumor. Can you imagine this carotid artery is located here? Carotid artery is not within the confines of the tumor. This has huge implications when you are going to operate on this tumor. So when you operate on this tumor from a lateral perspective, there is no carotid artery here. There is no carotid artery in the entire tumor. This concept has huge implications when you are going to operate on cavernous sinus. You must also know that when you are operating on the cavernous sinus, the cranial nerves of the cavernous sinus are displaced on the dome of the tumor. So when you are operating on this tumor, there is not a single cranial nerve in this vicinity. Having this information has got absolutely very great implications during your surgical performance. So the bone is destroyed, cavernous sinus is displaced on the dome, internal carotid artery is displaced anteriorly by the tumor, and then petroclival chordomas, which is a very common location for these tumors. You can come anteriorly in this direction and you can operate this tumor in a very philosophical manner. This article of mine published in 1995, middle fossa approach, middle fossa subgastrian ganglion approach to clival chordoma on the basis of understanding of the dura, understanding of the cavernous sinus. You can come in this direction. If you think, on the other hand, if you do not have this information that the dura is going to be present, it means if the dura is not present, this tumor is going to encase the basilar artery. You must remember that the basilar artery is encased in an absolute rare situation by these tumors. Absolutely rare. The dura is present. You respect the dura during operation. You work within this tumor. You avoid coagulation. You demolish this tumor. The tumor has broken the bones here. If you work under the gastrian ganglion, you remove this tumor. So I consider this approach of mine a very philosophical approach. This tumor is in the extradural compartment. Many of these tumors, of course, can be removed from a transnasal extradural approach using endoscope. But there is a huge number of tumors where transcranial approach is still the most viable and most beautiful option for these tumors. If this tumor comes, you can of course come from the nose. But transcranial, you see transcranial under keeping the internal carotid artery under your control, keeping the cranial nerves under your control in an extradural resection is an absolute beautiful approach. Under no circumstance you can say that transcranial approach is not a viable approach for chordomas in a number of tumors. I'm not saying in all the tumors. Many tumors are located right into the sphenoid sinus, located in the extradural situation. Those tumors may probably be resected by a transnasal approach, but there is still a very beautiful space for transcranial approach for clival chordomas. This tumor, you will not imagine this tumor I removed in very quick time. You see the carotid artery is displaced anteriorly by the tumor. Dura is displaced posteriorly by the tumor. There is dura preserved completely around the dome of the tumor. This carotid artery was a diagnostic feature for me during surgery. If you see the carotid artery on the anterior dome of the tumor, it is a chordoma for sure. If the internal carotid artery is displaced on the medial surface of the tumor, it is trigeminal neurinoma for sure. if the carotid artery is encased by the tumor, it is neither a chordoma nor a trigeminal neurinoma for sure. It is either an intracavernous sinus tumor like cavernous hemangioma or a meningioma, which I will discuss later. So this relationship of clivus tumor with the internal carotid artery makes it absolutely diagnostic of clival chordoma. Similarly, in this case, you see there is dura present here, there is dura present here. Under no circumstance, this is a pituitary tumor. This is a paranasal sinus tumor. Here there is tumor encasement of the carotid artery. This is a different tumor. So on the basis of dural relationship, you can have a very diagnostic kind of implication. This is a nasopharyngeal angiofibroma. Nasopharyngeal angiofibroma comes in very close proximity to the cavernous sinus. But you must remember that nasopharyngeal angiofibroma will never actually enter into the confines of the cavernous sinus. They will remain outside the cavernous sinus dura. There will be a thin shell of bone outside, and you can do a very different kind of dissection for nasopharyngeal angiofibromas. I had described in the year 1992 a transcranial approach for nasopharyngeal angiofibroma. But I will say that transcranial approach is not a good option. Transnasal approach, maybe if you are very versatile in the use of endoscope, you can use endoscope, but transnasal approach is not, transcranial approach is not the approach for nasopharyngeal angiofibroma. This is one tumor which is a very rare tumor, and this is an epidermoid tumor. This is an aspergilloma involving the cavernous sinus. This is a tuberculoma involving the cavernous sinus. This is a meningioma involving the cavernous sinus. When the tumor goes on both sides of the dura, meningioma is the mother of all tumors. Meningioma arises from the meninges and goes on this side and that side. No other tumor does. And it is a strong tumor, and it can encase the carotid artery, and it can squeeze the carotid artery. So the surgery of meningiomas involving the cavernous sinus is a different world. When to operate tumor within the cavernous sinus, when you have to manipulate the cavernous sinus dura, when the tumor arises in the dura, you can have a special relationship with the third nerve, but still the third nerve will be more often displaced by the meningioma, and a special wall is made around the tumor. When the meningioma arises in the region of a cavernous sinus and goes in the pitoclival area, it is a different kind of tumor. Your entire neurosurgical acumen will be required to remove the tumor, that is one. Your philosophical understanding of the tumor will be required as to when to stop and when not to manipulate the cranial nerves, when not to manipulate the internal carotid artery, when not to manipulate the basilar artery, when not to manipulate the perforators of the basilar artery, because this tumor is not, this is in the subarachnoid location. This location is varies with the tumor. Meningiomas are different tumor. They are the mother of tumors. Initially, we were, as I have mentioned, my exposures were all very, very extensive. When I used to do pitoclival meningiomas of this type, my exposure was quite radical. As you can see, this was done several years ago, maybe 25 years ago. I had done this case where my exposure was very, very massive. Now my exposures, and I used to mobilize the cranial nerves, mobilize the internal carotid artery. This kind of mobilization, cutting of the greater superficial petrosal nerve and mobilizing just the tympanic and the labyrinthine segment and not the mastoid segment from a middle fossa approach was described for the first time in the literature in this article. And this article is right in front of you. Those who would like to read, they must read. From the middle fossa approach, remove the base, roof of the zygoma, roof of the condyle, partial mastoidectomy, then partial removal of the mastoid bone, expanding of the Carotid Triangle, And working in this compartment, I used to do all these kind of exposures, which I will discuss in my subsequent lecture. But now my exposures have become rather small. For posterior fossa petroclival tumors, I described conventional. Of course, Sammy had described retrosigmoid approach for petroclival meningiomas. My approach was a most outstanding approach. We described supracerebellar approach for the first time in the literature about 20 years ago. Supracerebellar approach for petroclival meningiomas. You must know this. I may be able to show you some videos in my subsequent lectures, but supracerebellar approach is suitable and the most beautiful approach for petroclival meningiomas, a large majority of meningiomas. You must read this article of mine. You must note down this article. This will be on the net. Supracerebellar approach for petroclival meningiomas. This article also, I want young people to note down this article, and I want you to read this article when you go back home. It has got some most philosophical surgical strategies for cavernous sinus meningiomas. I'm sure young people are recording this article. Go back home and read this article, Surgery on
Okay, I think he fell
Yeah,
off.
yeah, I'm there.
Oh, there you go. Go ahead, Atul. You fell off the screen. Go ahead.
John, I'm here.
Yeah, that's okay.
Yeah, so cavernous sinus meningioma is a very tricky operation. And those who are in this business, I'm not saying all of you are young people here. I know some of you are very experienced people. Even if you are experienced, I wish you can read this article, which has got some very fantastic philosophical notes regarding cavernous sinus meningioma surgery. There are several articles of mine on various types of meningioma, anterior clinoidal meningiomas, and the grading system that I described in the year 2000, 20 years ago. I wish you can read it. 21 years ago, I showed my series of tuberculum celli meningiomas of 70 cases, which was the largest series in the world at that time. And my series is still largest in the world. I will talk to you about tuberculum celli meningiomas. So just to summarize, the strategy for treatment of meningioma is that curing is a non-issue. You cannot say I have removed completely and I have cured the person. This issue, curing, is a non-issue in the meningiomas. Once a meningioma, always a meningioma. You must remember, the most important thing is you must preserve all the function. I'm not saying that I'm able to preserve the function of all cranial nerves when I do the tumor. Don't misunderstand me. But my aim of resection is preserving the function and radical resection of all meningiomas. But complete resection and remove the cranial nerve is not my aim. Beautiful sentence I am giving you to all the young people in particular. Recurrence of meningioma is independent of the extent of tumor resection. So if I leave some tumor behind, that is not a failure. Tumor will recur even if you have removed it completely. So this statement of mine is my gospel, that tumor will recur on the basis of its activity, on the basis of its mitotic activity, and not on the basis of how much tumor you have resected. It is not the treatment, it is not the extent of resection, but the cellular behavior of the tumor that will decide the ultimate recurrence of this tumor, for any tumor for that matter, and for meningiomas in particular. So as neurosurgeons, we are entering into the field of skull base. We are entering into a complex field where we can create complications, where we can devastate a human being. We must put this plaque in front of your clinic. Every neurosurgeon should have a plaque in front of his clinic. There are some patients whom we cannot help. There are none we cannot harm. We should learn from our complications. There will be complications in our lifetime. There will be complications all the time. But if the complications are repeated on a regular basis, then we should stop operating. But if we have not learned from our complications, we have not learned neurosurgery. So I want to give you this message that we are not dealing with cadaver dissections, and we are not here to show our anatomical and technical skills. We are dealing with a very important person who has a life, who has a family, who has children, who are waiting to see the outcome of your operation. Whenever you operate, you have to be confident. You have to walk strong and tall, but you have to keep your head down. You have to respect the tumor. You have to respect the human being. And more importantly, whilst operating, you have to respect the membranes. You have to respect the blood vessels. You have to respect the nerves. And you have to learn to respect God. Thank you very much.
Thank you. Thank you very much, Professor.
And that is my presentation.
Thank you very much, Professor. The floor is open.
Thank you very much, sir. Excellent presentation, as usual.
Thank you for this opportunity to talk to the young people in the audience. And I know there are several young people and there are several young bubbling minds waiting to ask questions. And I will be happiest to answer questions to the extent I can. And I must also tell you that I am, of course, having a experience which is lasting about 40 years in this, but still I am young and I will be continuing as long as I am alive. And there is no way I can say that I am done with this. I will be. So you cannot say you are always young when you are operating. And all of you sitting here are, many of you are emerging into this field of neurosurgery. And I wish you well. You are sitting here in the audience because you love this subject of complex skull base. And I want you to ask many questions to me. And I'm waiting for your questions.
Floor is open.
Now there are some questions on the chat box.
Yeah, let's get there.
Let me try to answer the questions from the chat box.
Okay, one is Professor Goel, which tumors do not respect the dura?
It is like a child. Child has to respect the mother. Mother will embrace you. Mother will love you and squeeze you. Mother will never demolish you unless you are malignant in nature, unless you are malignant tumor. So I will say some malignant tumors do not respect and they may go here and there, but even malignant tumors respect the dura. Meningioma is the mother of tumors and it goes on both sides of the tumor. Some malignant tumors go on both sides of the dura, other than malignant tumors, and some pituitary tumors which take a malignant proportion, all the tumors respect the dura. That is my answer to your question. John.
Okay. Let's see. It's a question from Ashtok Gandhi. Do you believe in various compartment of cavernous sinus, how much they are important in surgical approaches?
Yeah, that is a very, very fantastic question. Beautiful question. And this compartmentalization of the cavernous sinus was initiated beautifully initially by Vinko Dolenz. Parkinson's Triangle was introduced by Dwight Parkinson, and the whole era of cavernous sinus surgery started from there. These are anatomical concepts. Dwight Parkinson, you must know the Parkinson Triangle, and Parkinson Triangle was, during that time, dural cavernous sinus fistulas were approached from Parkinson Triangle, from meningo-hypophyseal trunk of the cavernous sinus. You may not know, but during that time, there were surgeons who were operating on cavernous sinus dural fistulas. During my era, cavernous sinus surgery for dural cavernous sinus fistula surgery was the most prominent type of surgery, and Parkinson's Triangle was the very famous triangle at that time. Vinko Dolenz introduced this extradural approach, and intracavernous aneurysm surgery was the most beautiful surgery 35 years ago, and most fascinating for a person who was going to do technical neurosurgery. But then interventional neurosurgery came into picture, interventional neuroradiology came into picture. Now cavernous sinus dural fistula are no longer surgical field. Many of the aneurysms within the confines of cavernous sinus, we were doing bypass after bypass, bypass after bypass. That was our passion and our fascination, to do bypass and then block the carotid artery. Now many of these cases are done by interventional radiological treatment, and bypass surgery has become a very rare kind of event. To understand the compartments and understand the various triangles of cavernous sinus is a very beautiful thing to learn the anatomy. And I must say, when you are developing your business, Fukushima had presented very number of triangles of cavernous sinus. I had also presented one triangle in my early days. So triangles are a way to learn the anatomy, and also respecting the triangles whilst working on the dura of cavernous sinus is a good way. I will not say not knowing the cavernous sinus is a good way to learn cavernous sinus. You must go into the cadaver dissection hall and learn various compartments. That is a beautiful way to learn the triangles, to learn the interclinoid ligament, to learn the ligament from anterior clinoid process to the posterior clinoid process, to learn about the ligament that goes from the tuberculum celli to the cavernous sinus. You have to learn how the tentorial edge goes along the anterior and posterior clinoid processes. Learn various ligaments and various triangles. I think it is important to know the triangles. That is my answer to your question.
Okay, this question is, I guess, for both IPA and you, Dr. Goel. Can you explain the advantage of extradural removing of clinoid in comparison to intradural?
See, as you develop into the field of clinoid process removal, Vinko Dolenz became instantly a hero, superhero in the world of skull base, in the world of cavernous sinus, by developing one approach he described, and that was removal of the anterior clinoid process, and he instantly became superhero in the year 1981, 1982, he described this. And then, of course, he went on to describe how to remove anterior clinoid process to tackle the anterior clinoid region, paraclinoid aneurysms, and things like that. He also described removal of anterior clinoid process to remove meningiomas, to remove trigeminal neurinomas. But if you really ask me today, yes, what is my answer to that question? I remove anterior clinoid process only for resection of paraclinoid aneurysms, and rarely for some meningiomas of the anterior clinoid process. Otherwise, for all tumors like trigeminal neurinomas, I do not remove the anterior clinoid process. I do not remove anterior clinoid process, for that matter, for any tumor other than some little meningiomas. As you develop your experience in removing anterior clinoid process, extradural removal is the most philosophical method of removing anterior clinoid process. As I mentioned in my article, you see, we have to learn embryologically. The dura comes first, anterior clinoid comes later, and anterior clinoid process goes inside the, you see, in that compartment, it will always preserve the dura. Anterior clinoid process, when you are removing, the dura will always be present. So if you know your skills of dural, if you know your skills of bone resection, extradural resection of anterior clinoid process is the best. But if you are developing your exposure early in your experience, you see, when you go intradural, you cut the dura, it is safer to remove the dura under vision, you remove the anterior clinoid process. But my answer to your question is, if you want to save the third nerve, which is by the side of the anterior clinoid process, third nerve is very close to the anterior clinoid process. So if you go intradural, there is a possibility of damaging the third nerve more often. Then if you go extradural, the possibility of damaging the third nerve is less predominant. Like you preserve the optic nerve, you go to, as I was showing the optic strut, how you preserve the optic strut, you preserve the falciform ligament, you go, that is, then develop your exposure. Once you have got the internal carotid artery in your control, you may even not need your neck dissection. I must tell you, I don't ever do neck dissection for last 20 years. If you have confidence in working within the respectful boundaries of the dura. So that is my answer.
Okay. Okay, I. More comments, questions? Now's your chance.
I want the young people to ask me many questions.
Yeah, are they here?
That's the problem.
To ask a question.
When
There is a tumor, when
Yes,
there's a tumor
Khalid.
that has when there's a tumor that has infiltrated the cavernous sinus, is it true to assume that the bleeding will be less in that surgery because the venous channels have been obliterated by the tumor? Is that a correct thinking?
No, that is not probably a correct thinking. You see, what happens is, like for trigeminal neurinoma, you have to work within the dura and there will be no venous bleeding. And when the entire tumor is removed, if you open the medial dura, there will be a sudden gush of venous bleeding. So, of course, what you said was correct, that it obliterates the venous bleeding. It obliterates the venous sinuses.
Okay.
But you work within the confines of the dura, you may not get into. But that what you are saying is more relevant for a meningioma, for instance. When you remove the meningioma, if venous bleeding starts, it means you have removed it radically and more completely. So that is the answer, Khalid, for you.
Thank you. Thank you very much, Prof.
Thank you, Khalid.
Hello.
Yes, yes.
Go ahead.
How to debug the tumor without using a dithermic?
That you have to learn. That is the life. You have to spend your life to learn that. You have to spend your whole life to learn this.
Give some hint.
And you have to, if you know, I cannot show you by my speech or by my fingers how to remove the tumor. I will show you some videos. And if you are really interested and if you are really inquisitive, you have to make a trip to my department and spend some days with me. I cannot, I am saying, learn the art of demolishing the tumor. Learn the art of removing the tumor without coagulation.
Give some
I
hints.
say very many times that you When you coagulate the tumor within the confines, you are wasting your time. When you are coagulating outside the tumor, you are making a technical error that is relevant more for acoustic tumor and for trigeminal neurinomas and for some other tumors. It is very important to understand what I'm saying. You know, I know you have questions. I know everybody in the world may have questions.
When should I come, sir?
Like pituitary tumors, they are huge tumors you can do without a single coagulation. And there is no, you don't ask me any further question. If you are still inquisitive in your mind, you have to come and spend some time with me.
When to join? When to come?
Okay?
When to join?
When the corona is finished and I am out of quarantine.
Okay, thank you.
Okay? Okay.
Thank you. More comments, questions? Okay, well, Dr. Guo, thank you very much. Another great classic. What's the topic tomorrow?
My topic is surgery for Chiari malformation.
Oh, okay.
Surgery for Chiari, I will send you on internet. Surgery on Chiari malformation.
Great, great. We look forward to
Okay.
seeing you.
Okay,
Okay, thanks everybody for coming, and we'll see you tomorrow.
Thank you, Ike. Bye-bye.
All right.
Thank you. Thank you, sir.
Thank you.
Thank you, sir. Thank you so much, sir.
Thank you. Bye-bye.
Bye.
Thank you, sir.
Thank you, participants.
Yeah, Dr. Well, we're over now. I mean, we'll stop recording, but this is a chance for anybody to say hello to Dr. Goel. Dr. Shock, you want to say hi to Dr. Goel? She's always the first one in class.
Hello.
Good, yeah, say hi to Dr. Goel. What's your name and where you're from? What's your name and where you're from?
Hello.
Yeah, we can hear you. Go ahead. Go.
Oh, sorry. Good evening, sir. I'm Dr. Sarwar from Kolkata, resident neurosurgery.
Okay, welcome.
Sir, we met Goel sir 2 months back in Kolkata when he was here. Okay. So you remember?
I don't know if Dr. Goel, you still here? He may have stepped away or been taken away by the internet.
Okay.
Dr. Dung Gaga from Nigeria, you made it. Hello, Dung.
Yes, I'm here. I did.
You got your camera there working?
Yeah.
Okay.
I should be up in a few minutes, in a few seconds.
Yeah. Oh, well, we want to meet you. Hey, nice to meet you.
Same here, sir.
Okay, good. Are you enjoying these? I know you came early. Are you enjoying these lectures?
Yeah, absolutely. I've been enjoying every bit of them.
Great.
I've been jumping in and out though because of work, but so far so good. Had a wonderful time. Thank you for having me.
Yeah, we have Africa Grand Rounds tomorrow. I'll send you the poster. Okay.
Okay, sir. Thank you.
Okay. And anyone else that wants to introduce themselves to the community here that's with us? Anybody want to say hello? Oh, hello, Dr. Gopal. Could you please introduce yourself?
I'm Dr. Gopal from Kathmandu in Nepal.
Oh, okay. You're at okay. I went to Bharatnagar for 3 months.
Okay, nice.
And I spent time in Kathmandu. I really liked it. Excellent. Nice to meet you, and you can come back anytime. Anyone else? Dr. Uday, how you doing?
Fine, sir. It was a wonderful presentation, and all the topics were very relevantly covered. And Professor Atul Goel is a prolific orator. He mesmerizes all the audiences when he speaks.
Does. He has a unique style, isn't he?
Yeah, he sees us sparking with energy.
Yeah, he's unique style. He's very captivating, enthusiastic. He does capture you.
So today's lecture was more of a philosophical lecture.
Yeah.
And he tried to break many boundaries by delivering such a lecture, that how to correlate from fishes, birds to animals, about the cavernous sinus. So these all things were very new to hear from a master like Professor Goel.
Yeah, when he showed those slides of the animals, I thought, is he showing his trip to Africa or something? But no, he was just trying to illustrate a principle. Yeah, it was good. It surprised me.
Surprising.
Okay, anyone else? Go ahead. I'm sorry.
Sir, I just wanted to have, because we are not getting a clear link before these lectures. At least they should be disseminated about 4 or 5 hours before the start of
Good.
the.
You can help us then.
Yeah.
I'm not an expert. I'm an expert, but I'm learning.
I'm trying to do it in my own community, but I wish more and more people should join and attend these types of academic feasts.
Well, we put the link all over Facebook, and we'd appreciate if you just pass it on to your followers, because you got in pretty easy, right? I think most people get in okay. And it takes a little learning, like everyone's really good with the mute button. I think that's because you're neurosurgeons. You realize the importance of the button. And, you know, that's nice to go through almost the whole conference without too many sound interferences. So technically, I think the community will learn this platform better and better. I think once the audio gets really good for everybody, that'll be a higher grade of conference when everything, you know, that's the one thing that we got to work on, the audio. But then again, I don't want to exclude anybody because sometimes people don't have a good connection, and you know, I want them to come and see it at least. And even though sometimes the audio's not good, we put up with it. You know, when Dr. Goel's went off, there's not many people that left. Everyone stayed.
Everyone's sitting. Yes.
Yeah, I thought everyone would start bailing, but no, everyone stayed.
He will return back with a bigger bang.
Yeah.
He returns back.
So, okay, you guys, I gotta get going. Come back tomorrow. We'll see you tomorrow.
Tomorrow.
Bye.
Bye-bye. Bye-bye.
Thank you. Bye.